What is hypovolemic shock? Hypovolemic shock, it is also called hemorrhagic shock. It is an emergency condition in which severe blood and fluid loss, more than 20%, one-fifth of your body's blood or fluid supply, make the heart unable to pump enough blood to the body. This type of shock can cause many organs to stop working, and the condition requires immediately emergency medical attention in order to survive. Let's watch a video that explains us better the concept of hypovolemic shock.
Or hypoperfusion is the inability of the circulatory system to supply cells with oxygen. In early stages, symptoms occur as the body attempts to compensate for blood loss. Physiological causes of shock are the heart failing to pump, loss of blood volume, or blood vessels dilating, creating a vascular container capacity that is too great to be filled by available blood. Categories of severity are compensated shock, presents as an increased heart rate, increased respiration, and constriction of peripheral circulation, which results in pale, cool skin, and in infants and children, increased capillary refill time. Decompensated shock starts with low blood volume or lack of perfusion. Symptoms include falling blood pressure. Shock is irreversible when perfusion to the organs cannot be restored. Cell damage occurs, especially in the liver and kidneys. Even if vital signs are restored, irreparably damaged organs may cause death. The main types of shock are hypovolemic shock, caused by uncontrolled hemorrhage, internal, external, or both, or by plasma loss in burns or crush injuries. Cardiogenic shock occurs during a myocardial infarction or heart attack. Damaged heart muscle or electrical malfunctioning decrease the strength of the heart's contractions, causing a slow, fast, or irregular heartbeat. Neurogenic shock may result from the uncontrolled dilation of blood vessels due to nerve paralysis in spinal cord injuries. There is no blood loss, but the blood vessel dilation increases the capacity of the circulatory system, and available blood can no longer fill it. Sepsis, massive infection, or an anaphylactic or severe allergic reaction may also cause shock from blood vessel dilation. As an EMTB, you do not need to diagnose the type of shock. Instead, you must recognize and treat for shock whenever there is a mechanism of injury or signs that indicate the possibility of shock.
So thank you for this video, and let's go to our next slide. It talks about the causes of hypovolemic shock. The losing about one-fifth or more of the normal amount of blood in your body causes hypovolemic shock. Blood loss can be due to bleeding from cuts, bleeding from other injuries, internal bleeding such as in the gastrointestinal tract. The amount of circulating blood in your body may drop when you lose too many other body fluids, which can happen with excessive diarrhea, severe burns, protracted and excessive vomiting, and excessive sweating. So let's watch this video that explains us the causes of hypovolemic shock.
Our next topic is hypo, H-Y-P-O, volemia. And this condition relates to the absence of adequate fluids in the body. So you get a whole different picture of the patient here. The patient tends to be quite drawn, thin from their normal appearance. And their overall cognitive perceptual status involves a lot of confusion. Makes you a bit disoriented to be out of fluids. People become quite thirsty. And in terms of their heart assessment, there's a very rapid, thready pulse described as tachy or tachycardia. and the blood pressure is low. The patient's skin turgor and actual palpation of the skin reveals very warm, dry skin with decreased resilience, and their muscles show signs of weakness, and the patients often experience cramping. So what's a nurse to do? Well, treatment often involves treating the cause of the volume loss, correcting the cause of excessive urination, or treating diarrhea or vomiting, and providing rehydration through oral fluids or the use of isotonic IV fluids. Frequent oral care because of the dry, irritated mucous membranes in the mouth, and attention to skin care to avoid any kind of breakdown are also important. I&O monitoring, vital sign assessment are also, as always, important to do.
Our next slide talks about the symptoms. So what are the symptoms of hypovolemic shock? The symptoms may vary with the severity of the fluid and or blood loss. However, all symptoms of shock are life-threatening and should be treated as a medical emergency. Internal bleeding symptoms may be hard to recognize until symptoms of shock appear. However, external bleeding will be visible. Symptoms of hemorrhagic shock may not appear immediately. Other adults may not experience these symptoms until the shock has progressed significantly. So here we have a symptoms list. We have anxiety, fluid lips and fingernails, low or no urine output, profuse sweating, shallow breathing, dizziness, confusion, chest pain, loss of consciousness, low blood pressure, rapid heart rate, and weak pulse. Let's watch this video that explains us better the
Alright
symptoms.
guys, so let's get into our hypovolemic shock. And really, hypovolemic shock is really just the same thing as cardiogenic shock, almost, just on a different level. We're still decreasing pressure, which is decreasing our perfusion. But when we're decreasing pressure, we're talking about all of the hemoglobin in the blood, the oxygen transports in the blood, not being there anymore. We're decreasing that so we don't have enough perfusion around the body. So we're going to have pretty much the same clinical manifestations as cardiogenic shock, just a decrease in oxygenation. So let's get into it again. Okay. So by cardiogenic shock, we have less cardiac output, okay? So less cardiac output, all that really means is less oxygen, less pressure being pushed around the body. Almost the same thing as hypovolemic shock. Hypovolemic shock. We're having decreasing volume in the body, okay? So this decreasing volume comes in the way of bleeding, hemorrhaging. We're bleeding out all of our oxygen transports. So bleeding, and this can be bleeding from anywhere. So we're basically decreasing our hemoglobin. And our hemoglobin is just that red blood cell. Basically, we're just talking about bleeding out. Where the hemoglobin is that protein inside the red blood cell that carries our oxygen. really like our O2 tanks in our red blood cell. So you can think of hemoglobin as really just a red blood cell itself. And if that's decreased, then we're going to have decreased oxygenation. If we're bleeding out, remember we talked about volume and resistance. We're decreasing our volume again in our pressure, so our pressures drop. This is going to have a direct impact on our oxygenation because no more red blood cells around the body. Because all bleeding out, we're going to have decreased hemoglobin, which decreases our oxygen. So in terms of your clinical manifestations, your patient can come in for, let's say, a trauma. They just got in a bad car accident. They have a seatbelt that has just crushed, let's say, their liver. Now they have a split liver. Or they have a GI bleed, a bleed inside their intestines. Or let's just say they have a massive wound from a gunshot wound, and now they're bleeding out profusely. Or, I don't care how you are bleeding, you're bleeding, right? Bleeding is bleeding, wherever it is. You can be sliced up with a knife. You can be stabbed. You're just bleeding, and this bleeding leads to our decreased hemoglobin, decreased blood cell, decreased H&H. However you want to call it, you're bleeding, and you're losing this blood in your body that carries oxygen. So, if you have decreased oxygen in your body, or decreased pressure, your body compensates in the very, very same ways. And you have the same clinical manifestations. So, you have an increase in your respiratory rates. You're starting to breathe hard now. Trying to get more oxygen now into your bloodstream. Your heart rate is going to increase because it's trying to transport that limited blood around the body now. So we have a decrease in volume, okay? This is going to cause an increase in resistance. We're going to start vasoconstricting. Those vessels are trying to now bring more blood back to our lungs, bring more blood back to our heart, and bring more blood back to our brain. That's really what you need to live. And your kidneys now are going to start holding on to all the fluid it can hold on to. So, we're going to have our decreased urinary output, okay? Because we don't want to lose any more volume than we're giving out. We're going to have an altered level of consciousness. Why? Same thing, guys. Decreased oxygen. Your heart's going to try to compensate, pump around that limited blood supply around the body. And how are your skin going to look? Your skin are going to look very pale, very blue, very cold, very dusky, as we like to say. Pale is the same thing as dusky, pretty much. Decreased cap refill. All that means is decreased oxygenation, okay? That's really all it means. So a lot of your septic patients, a lot of your shock patients are going to all manifest decreased signs of decreased perfusion, decreased oxygenation. And once you guys understand that the body runs on oxygen to survive, and if once oxygen is manipulated in your body, everything tries to compensate, and everything starts going haywire. So, what do we do for pharmacological aspects of it, or nursing interventions? One of the things we do is we stop the bleeding, right? We want to put pressure. We want that bleeding to stop, so we put pressure on that site, and hopefully it'll coagulate. Hopefully we stop the bleeding at direct pressure. So we stop the bleeding. We're trying to increase the volume at that point. What else can we do? Well, we can put more system, right? Increase the volume, right? That will work, right? So give the patient a blood transfusion. Not too shabby, huh? So we're trying to increase the volume of blood now, increase those red blood cells to go around the body and oxygenate again. We can increase the resistance of your peripheral vessels. We can give your patient epinephrine, right? That adrenaline that shrinks down the vessels in your peripherals, right? We can put your patient on a dopamine drip. A dopamine drip is just a fancy word for we're shrinking down those vessels in your peripherals, increasing the blood pressure. And what is pressure again? Increasing oxygenation in your body. Now, don't think that hypertension is an increase in oxygen, because really oxygenation, decreased oxygenation, really only comes with decreased pressure. Okay? So hopefully that makes sense a little bit. So, if you guys understand that decreased pressure, decreased O2, and your body compensates with decreased O2 in these areas, then you guys are on the right track. It's really that simple once we understand that. So let's get into anaphylactic shock, which really is a decrease in resistance. And that's just on the other side of our little teeter-totter. So our cardiogenic shock and our hypovolemic shock, or bleeding, is really all about decrease in volume. Let's talk about a decrease in resistance now. Let's do it. That wasn't that hard, was it? Hopefully that wasn't that hard to understand.
Now let's watch a video talking about the treatment that we should apply for
Well, welcome to another lecture. We're going to talk about the treatment for shock. Please refer to the lecture called Shock Explained Clearly for the background on that information. But what I'd like to get into is the treatment for the different types of shock. Okay, the three different types of shock we're going to talk about is number one, hypovolemic. Number two is cardiogenic. And number three is septic. And you will remember that we talked about the different pathophysiology of these shock syndromes. Hypovolemic starts off with a low amount of volume in the body from either bleeding or dehydration or blood loss, and that can cause a low JVP, which will cause a low cardiac output and a high systemic vascular resistance. And then what will happen is that the target organs will eventually lose oxygen and they will start to fail. Cardiogenic shock is where the heart initially starts to fail. That causes a decrease in blood pressure, decrease in cardiac output, not enough blood getting to the target tissues, lack of oxygen, and shock again. Septic shock, on the other hand, is where there is increased flow from the heart, increased cardiac output. However, there is a drop in the systemic vascular resistance. There is deregulation of the blood going between vital and non-vital organs, and because of that, the vital organs lose out, and they start to go into septic shock. And I think the picture that we drew for that resembled this type of a picture, where we had the bucket, if you will, filled up with the fluid, and then we had the pipes that were leading from there to go to the heart, and then it went off and branched into two different organ types. There was the vital organs, okay, put a V for vital, and there were the non-vital organs like skin, okay, so non-vital organs. And all of this sort of came back together again to complete the cycle. And we said that there are different areas where we can have problems. And I think we labeled those A here, hypovolemic. If your volume is low, that's going to cause problems. The second one was B, or the heart. That was cardiogenic shock here. And obviously if the heart pump is not working very well, that's going to cause you some big problems there as well. And then finally, the septic. Now that seemed to be a problem here in the vasculature, and indeed just about everywhere. You're going to get vasodilation more than others, and so blood may go to the non-vital and not so much to the vital. Okay, so let's talk about the treatment solutions. First of all, let's talk about hypovolemic shock first. Alright, so in hypovolemic shock there is a loss in volume. And so what's going to happen in that situation is there's going to be a stimulus to replace that volume. And the two biggest factors that you're going to see there is the RAS system, or the renin-angiotensin system, with aldosterone. Okay, and the next one is ADH. Now, if you will recall, the renin-angiotensin system is a system or situation where aldosterone is secreted from the zona glomerulosa of the adrenal cortex. Please see our lecture on adrenal cortex for further information on that. And that hormone, which is a steroid hormone, is secreted from the zona glomerulosa of the adrenal cortex and works in the, if you recall, the distal convoluted tubule of the nephron to reabsorb sodium and therefore water. And that's going to increase the volume. So that's going to work. Now the second thing that happens is the antidiuretic hormone, which is secreted. Now if you recall, antidiuretic hormone is produced in the hypothalamus and is secreted in the posterior pituitary. And that hormone is a protein hormone, so it works very rapidly, and that works on the collecting tubule of the nephron, and that helps reabsorb water. Now, ADH is, the other name for ADH is vasopressin. And we can actually give vasopressin to patients as a vasopressor. So this is a very potent volume expander, and so is the renin-angiotensin system as well. So that's what the body is doing. And obviously the body is doing this very early, but if it turns out that this is still not able to compensate for the tremendous amount of volume that's being lost, you're going to decompensate and you're going to go into multi-organ dysfunction from hypovolemia. So if this patient makes it to the emergency room and the intensive care unit, what we're going to give is basically normal saline. You're going to give it quick, and you're going to give it fast because you have it available, it's easy to give, and you don't have to worry about transfusion reactions. Obviously, however, if the patient is bleeding, you're going to do a transfusion. And you're going to have to give that pretty rapidly. You have to type and cross these patients, make sure there's no antibodies. And so the bottom line here is the treatment for hypovolemia is volume, and that makes sense. Okay, so let's talk about the second form of shock, and which is cardiogenic shock. Now, as you know, cardiogenic shock is a problem specifically with the heart. There is medications which we can do to make the heart beat stronger. One of those is the digoxin. This works especially well when the heart ejection fraction is less than 40%. So think about that. You have to dose it, you have to load them, and you also have to monitor them. In the acute setting, however, as you know, there are beta receptors on the heart. Beta receptors cause the heart to beat stronger and faster. And so if you really want to stimulate the heart to do that, you should give a medication intravenously which has pure beta stimulation. And the name of that medication is dobutamine. Now there are other drugs that also have beta. Dopamine is one of them, but it also has dopamine receptors and alpha receptors, and dopamine can make the heart beat faster as well, and it can cause tachyarrhythmias. Dobutamine can also do that, but remember, dobutamine is pure beta. Now, something you got to know about that, though, is beta receptors are also on the vasculature, and that causes vasodilation. So beta, dobutamine, could actually make your blood pressure go down if the offset in increased cardiac output is not enough to take in consideration. So to review there, beta receptors both in the heart, beta receptors in the heart cause the heart to beat stronger and faster, And there are beta receptors in the peripheral vasculature, and beta receptors there cause vasodilation, which could cause hypotension. So if someone is in cardiogenic shock, you first of all want to find out why they're in cardiogenic shock. And if it's there because of a low ejection fraction, you may want to consider dobutamine. Remember, these patients have high central venous pressures, are cool to the touch, etc., etc. The treatment there is not necessarily volume, but what we call inotropes and chronotropes. That's what dobutamine is. All right, let's talk about the last one, which is septic shock. And for that, I'm going to go ahead and clear the screen. Now I'm going to
So we have the treatment, and now we are going to watch a video that explains us hypovolemia and fluid responsiveness in a patient. So let's listen what it is about. We have the objectives, the static, absolute number, right atrial central venous pressure, pulmonary arterial occlusion pressure, right ventricular. We have the dynamic change with respiration, right atrial pressure variation, pulse pressure variation, systolic arterial pressure. So why do we give fluids? We give fluids in an increase in stroke volume or cardiac output. Here we have a graph. A predictive fluid responsive in ICU patients. We have significant difference, but RAP and CVP mark overlap of CVP valve. We have pulmonary arterial occlusion pressure. We have it here. Pulmonary arterial occlusion pressure, no specific PaOP threshold to discriminate responders from non-responders. We have right ventricular and diastolic volume, no difference in those who they mark, and now we have a significant difference, but a right ventricular and diastolic volume. Right ventricular and diastolic volume with conflicting evidence. We have RVEDVI and left ventricular and diastolic area. We have an echograph. We have here the area, the one purple one, and we have the left ventricular and diastolic area. Here we have a table explaining us it better. This is a project made, and here we have the results that we got, that we gathered from the project. False assumptions that they made. Diastolic dysfunction is another false assumption. The incidence of ICU patient with diastolic dysfunction is a 50%. Mitral stenosis, mitral regurgitation is also a false assumption. Here with an echograph. Another false assumption, pulmonary hypertension with hypoxia, hypercardia, acidosis, pulmonary embolism, obstructive sleep apnea. False assumption, pulmonic valve. Another false assumption, tricuspid valve RV failure. we have a tricuspid regurgitation and then a right heart failure. And that's it. Thank you for watching the video, and thank you.